much. Next up, we have Dr. Steve Arshinoff, who needs no introduction. He's joining us from Canada, and he's going to be talking to us about approaching a new problem for selection of ideal OVDs. Can we have Sir's slides over here, please?
Yes, thank you, Sarban. I'm sharing my screen. Can you see the presentation?
Yes, I can see your home screen, yes.
Okay, well, thank you very much. Firstly, thank you for inviting me to take part in this wonderful meeting as always. It's just always incredibly impressive to see what the SETIs do on all these wonderful occasions, and it's a great honor to take part. So I'm going to talk to you really about a problem, but of course it's a first world problem where I live, and we get problems too. And the idea is how we can use some knowledge of OVDs to make problems that look to be quite difficult when they suddenly appear much easier for us. So my disclosures, I consult for almost everybody who makes OVDs, so I don't think I'm biased for one from the other. So the general proposition is that OVDs allow surgeons to modify the rheology of the anterior chamber in a specific targeted way to facilitate whatever the planned maneuver is that we're going to be going after to try to make things work better. So the basis of this is that our OVDs are capable of creating different pressures in the eye. And some of us like to do high pressure surgery using Helon 5 or Helon GV. And these also have a pressure range really of a factor of 10 to each other, with Helon 5 being much more viscous and cohesive. And then we have lower pressure surgery with Helon or Visco. It is, again, a factor of 10 lower than Helon GV. And those who use very low pressure, most commonly in India and countries like that, where you don't want to always pay for very expensive OVDs. And so we have a huge range, really with a factor of 1,000,000 in terms of the viscosity and the pressure we can induce in the anterior chamber. And you choose these just to make some step of your surgery easier. So if you look at a simplified classification of OVDs, it's actually quite complex because we have many OVDs around the world, easily over 100, probably 200. And so we started off with lower viscosity dispersives and higher viscosity cohesives. We then developed a soft shell technique. We then got viscoadaptives and viscous dispersives. And now we have this myriad of OVDs. And that isn't even including HPMCs, which really don't have very high zero shear viscosity and don't enable us to pressurize the eye very much. But how do we choose among these and be able to make something easier? So I'm going to start off with the problem, and then this mostly is background, and at the end I'll show you the problem that occurred. So the issue is that we can get femtocapsulotomy tear-outs more often with femto than we see with regular phaco surgery. This was first talked about in 2013, where the ASCRS commented that the initial tear-out rate of almost 10% was dropping towards 1%. But 2 years later, another article of a series of 4,000 cases showed that the incidence of capsulotomy tear-outs was 8.3 times higher with femto than it was with phaco. So how do we solve that? Well, I published a paper in the Canadian Journal a couple of years ago talking about how you can solve it, and I'll go through that and tell you a basic way that we use to prevent having these in most cases, and then show you how something happened that was actually very different and maybe look at things a bit differently for that one specific case. So the first you have to understand is that all of our eye surgery is rheology. Other than changing the parameters of our phaco machine, all we can do to make things easier for ourselves is change the rheology of the anterior chamber. And the more you understand rheology, the easier it's going to be for you to deal with any problem that comes up. So here's what happens. We always look at things in terms of physics. And so simply put, what is the problem with a femtocapsulotomy with respect to physics? And the simple issue is that the laser produces gas, and this gas increases the pressure inside the capsule, and that pressure makes the bag expand outwards. And so if you have any nick or a postage stamp type perforation of the capsule, it's going to want to tear out. That's fundamentally why you get more tears with femto than you do with phaco. So how do we solve the problem? Well, you can solve the problem if you exert greater pressure in front of the capsule than you have behind it, because the atmospheric pressure we endure is high, but because it's the same all around us, we don't care. It looks like no pressure. So it's a difference in pressure between what's in front of the capsule and what's behind it that makes a difference. not the absolute pressure. So the idea here is to somehow increase the pressure in front of the capsule. So what you look at is see if we have anything similar. And we do. We've been dealing with Argentinian flag sign for a long time, and we really should never ever see Argentinian flag sign. And let me explain to you why. We published this, and I'll just show you what you talk about. So there's constant posterior pressure. These arrows show that the muscles are always pulling backwards. And the difference between a hypermature cataract and a regular cataract is that a hypermature cataract, when it really becomes hypermature and not the videos you see people showing, it really becomes a liquid. And when you have a liquid, the mature lens will not prevent transmission of posterior pressure. So it's not that the bag itself is swollen, but it's become a fluid and acts like a fluid and allows the pressure to be transmitted right through the lens anteriorly. And so the pressure behind the anterior capsule exceeds the pressure in front of it. And unless you depress that capsule with a viscous, cohesive, elastic OVD, you're going to have a hard time doing the capsulotomy. As soon as you puncture the capsule, it's going to want to tear out like a balloon will when you puncture with pressure behind it. So here I'll show you how you deal with these. And I kind of cheated in not having a really very liquid capsule here, but this is the technique. You fill the chamber with Helon 5 because it's very viscous. You paint across trypan blue, and then with a needle, you very gently do the rhexis so that you don't open the wound enough to allow any OVD to leak out. And the pressure allows a very smooth capsulotomy to be done without affecting the nucleus whatsoever. So the brief summary of that is every successful method ever proposed to deal with Argentinian flag sign uses some variation of pressure equalized cataract surgery to stabilize the capsule before creating the rhexis. Whether you put a needle in, hoping that it won't perforate and aspirate cortex, or whether you put OVD in front, all you're trying to do is balance the pressures. Putting OVD in front before you tear the capsule is much safer, but all these techniques work. Okay, so why is flax similar to a hypermature cataract? Well, in a hypermature cataract, we have necrosis of lenticular contacts, making the lens behave like a fluid and allowing transmission of posterior pressure. It's not really a swollen lens. It's usually just transmitted pressure. But in flax, the laser-induced intracapsular gas gives us truly increased intracapsular pressure, irrespective of any pressure behind. With increased intracapsular pressure, as I said before, the capsule will want to tear outwards. So what do? Well, in regular flax, should you use a very high viscosity OVD like Helon 5? Well, it'd be great, but the problem is that Helon 5 comes with a 25 gauge cannula, and sometimes when this capsule is pushed forward and you approach the eye after doing the femto part of the procedure, it's very hard to get the cannula in front of the flap. So I like to use Helon or Helon GV because the eye is basically closed before we do anything, and you can place it anywhere you want because the cannula is thin. It's a thin wall 27 gauge cannula, and you can inject the OVD in front of it and depress the center till you pressure equalize it, and then you can do the capsulotomy. And you can inject either from the side port, the main incision, any way you can, so that if you have part of that capsule rolling up and part attached, you can push back and flatten the capsule and not go behind it. So here I'll show you two videos. Here's a patient who looked like over here on the left side, it wasn't detached and the capsule was not free. And as I inject and pressurize the eye, watch, it seems to start to separate, but I'm not sure that it's free. So I take these forceps I like, the Haldane-Purkar masculine forceps, that I'll show you soon why I like them. And I put it in the eye and I depress. And as you depress, you see that the capsule starts to come away from its surrounding capsule. And so the capsulotomy is okay, and you take it out. Okay, forget that one. Now look at this one. This is a much worse one. You can see that really half the capsule here is still attached to the peripheral capsule. So I'm going to inject the OVD, and I'm going to come in with the forceps, and I do what I call a Gillesian capsulotomy, because James Gills always pushed the capsule posteriorly rather than folding it back and taking it anteriorly. And as you push backwards and pull towards the center, you see the capsule comes away, but you're going to watch it disturb some of the bubbles, which tells you that it wasn't detached before. And now it's free from going all around. You pinch it, take it out, you now have a normal, easy case. So you can get by and make the capsule normal even when it doesn't go properly all the time. These are the forceps I like. they have a very, very thin, long forceps, and you have a little tip that's sharp at the end that allows you to depress the capsule where you want to do that. So it just makes it easier. Okay, then the problem. Well, on August 23rd of this year, I was doing this lady's bilateral cataract surgery with a femto, and she was a little bit nervous, to understate what she was like. And as soon as I touched the pedal, she jumped. So what I was left with was a lens like this, where the capsule itself was not perforated. There were little dots that were not quite touching. So it was a fine postage stamp attachment of the capsulotomy flap to the capsule all the way around, and nothing done to the lens itself, because after 1/10 of a second, the femto spontaneously turned off. So how will I approach this case? Well, the first thing you have to do is you have to consider what exactly is happening here in terms of physics. So first, we have no flap elevations. It doesn't matter if the cannula of the OVD is thinner or thicker, and there's very little gas in the bag. So it really isn't an overpressurized bag. It's just a postage stamp capsulotomy. So what you want to do here is, unlike the Flax OVD press, here the incision will have to be opened, and I'm going to have to insert forceps and manipulate the flap all the way around. And so it's much more like doing a Gilsian rexus in an Argentinian flag sign than it is like doing a Flax OVD press in a patient that has had a successful Flax procedure done. So here I'd rather use Helon 5 and depress the capsule much more stably, gently go in through the side port or then through the main incision and do a capsulotomy. So here's what I did. So I filled the chamber with Helon 5 until I saw the central capsule depressed. Underneath it, I put a very thin layer of xylocaine phenylephrine, which makes the capsulotomy easier. I started to cut over here with a needle, and when I got to make the first part of that spiraling outwards capsulotomy towards the capsule, I took the Halder-Perkar forceps and I pushed down and inwards to see if I was able to separate that flap. I did not want to fold it anteriorly, because peeling it upwards will tend to make the postage stamp tear outwards. And by going around very gently and slowly through the entire 360 degrees of the entire capsule, I could push the capsule centrally, posteriorly, and make it tear in and not tear out. And what happened is I got a perfect Gilsian capsulorhexis, and I went along and did the procedure, and the patient was perfectly fine. So the point of all this is you have to look at the physics of what's happening in your case. And then when you do that, whether it's a femto patient or a cataract patient or whatever you're trying to do, by balancing the pressures in front of and behind the capsule, you can complete the capsulorhexis and make things easy for you. Because when you haven't got a good capsulorhexis, the rest of your surgery will be difficult. And you have two kinds of problems. One is like an Argentinian flag sign or a barely started femto. And in those cases, you want to use Helon 5 because there's no problem getting the cannula in the eye. You want to depress it until the pressure is high and gently go around and push the capsule posteriorly. But if you do a complete femto and you have an incomplete capsulotomy, then you want to use a Flax OVD press with the thin-walled Helon or Helon GB, which allows you to get in front of the capsule, push it back flat, deepen it, and then take the piece that wasn't finished and gently push it posteriorly, as Jim Gills taught us, and get a complete capsulotomy. So the idea of this talk was to show you how you subtly look at things and decide what exactly you want to achieve in terms of physics. And you choose your OVDs with a difference of the zero shear viscosity and pressure you can induce. And here between Helon 5 and Helon, it's a factor of 1,000. And you choose it based upon exactly what the situation calls for. And like everything else in ophthalmology, you do it calmly. You look first and then you maneuver. And it works better that way. Thank you very much. Questions are welcome.
Thank you so much, sir. That was indeed an interesting presentation, very interesting bunch of videos. We do have a question from Dr. Kelman here, where he asks, what laser platform are you using?
Oh, I use the Johnson & Johnson one. It's fantastic. It works very well. But I think it doesn't matter which one you use. They're all the same. They all, some of them have more difficult capsulotomies than others. For example, if you compare the Alcon one to the J&J one, the Alcon one goes around in a circle, whereas the J&J does it all in one shot. So they claim that it's better, but you still get sometimes these postage stamp attachments and you have to separate them. So I think even though they all claim that they're better than the other guy, in the end, you have the same problems. So it doesn't make any difference.
Experience with plaques and pediatric cataracts?
I didn't hear you, sorry.
Do you have any experience with plaques and pediatric cataracts in children? Cataracts, you have used
Well, you know, in Toronto, all the young children are done at Sick Kids Hospital.
Okay.
So I only do older ones that are more than, let's say, 12. And so I don't consider them children because, you know, a 13, 14-year-old will stay still and cooperate as good as an adult. But I have had a couple of 4-year-olds sent to me because they had trouble doing them downtown or in Hamilton. I'm a professor at both. And really with little children, the most important thing you do with them is you sit with the child and you have the mother in another chair and the child's on a chair by herself or himself, and you talk to them. And it's amazingly how well 4-year-olds cooperate if you talk to them. They know they have a problem. And if you talk to them and you treat them like people rather than like some little kid with a mummy holding them, they really do extremely well. And I've had one young child who at age 4 required me to laser her with a YAG to complete an operation that was partly done somewhere else. I had to laser her 4 times. And every time she was absolutely perfectly still and totally cooperative. And she was just terrific. So I think, you know, the trick is you don't rush them. If you talk to your patients, even the little kids, they do better. Now, I'm not sure a 2-year-old would, but 4-year-olds can.
Thank you. Thank you very much, sir, for answering all our questions. Moving on, we have